today. We're going to have Taylor Cottano from Southern Evals and Patty Harper from Inquisic that will be giving our presentation today. We are sponsored by Azalea Health and ChartSpan, and we appreciate your overwhelming interest in this subject. When I get on and talk about cost reports, I may get 7 or 8 people on one of these webinars, and we talk about infection control and COVID-19, and we have 500 people signed up. So that shows how poorly I think people think of Medicare cost reporting. That was a picture of me. This is a picture of Danny Gilbert, who runs the polls normally on these webinars. She's on vacation this week, so I will be running the polls. So if I completely mess them up, that will be the reason why. If you've not joined the Facebook group, the RHC Information Exchange group, we have, that says 850 members. We're now over 1,100 members. This is a very convenient way to post information, to ask questions. Patty Harper does a fantastic job answering questions on there, and occasionally I'll answer a question as well. So it's a very good resource. It's a closed group. We try to moderate it, so if people start putting weird stuff on there, we'll take it down so you don't have to see it. What does healthcare business specialists do? Besides doing these free webinars, is we do a lot of cost reports. Right now it's cost report season. We do about 170 cost reports each year. We work with emergency preparedness. We do TennCare quarterly reports because we're based in Tennessee. And we do a lot of RHC startups. One thing about startups is, I'll tell you real quickly, is a lot of the states have not been following the guidance from CMS about doing initial startups, but inspections, because we had 2 already this week in Tennessee where they're doing initial startup inspections. So you may want to call your state and ask them if they are still doing those startups instead of just going out and hiring Quad A or the compliance team automatically. Not that I want to take any business away from Quad A or the compliance team, but that could save you some money. Another thing we do is we have free seminars. We have those set up for Nashville 11/5 this year, Somerset, Kentucky 11/12, and then we'll be in Clanton, Alabama on 11/18. And Azalea Health is a big part of that, to making it where these are free seminars where you guys can go for free. And since we're talking about that, we're going to give Clark Bishop from Azalea Health just a couple minutes to tell you guys about Azalea Health as they are sponsoring this webinar. So Clark, I'll leave it open to you right now.
Thanks, Mark. I'm the regional director here with Azalea Health, and we're committed to rural. So we offer rural technology, a fully integrated platform, both for your practice management and EHR. One of our goals is to keep our client base and our prospects in the rural market educated. And so we're proud sponsors of events like this and some of the RHC free boot camps that we put on. Just this past week, we provided free telehealth to all of our EHR customers, mainly just to combat this COVID mess that we're in, and provide additional resources to our clients to help serve their rural communities. So we offer the full technology and the billing service. And if you haven't heard about us, we hope to meet you in person soon. Thanks, Mark.
Okay, thank you, Clark. We certainly do appreciate Azalea and ChartSpan as they've sponsored these seminars for us and these webinars. There's a lot of information that we've provided as part of this webinar. If we've set up a website called ruralhealthclinic.com COVID-19, and all of the materials for this webinar are on there. We are recording this session, so once it's been recorded, we will put it on there as a placeholder for it now. And so you guys can go back and view that, or if you have people in your organization that have not had the opportunity to view it today, they can get it at a later time. And we've put in all the links that Patty and Taylor have put in their presentation are right here in one place for you guys. And then we've added some additional information as well that we thought would be important. And we will update this as we go along with more and more information as well. Questions or comments, if you will, type your questions or comments into the sidebar over here. There's a question on the sidebar that you can put those in. We will wait at the end of the presentation because we have a lot of people on here, and we would probably get overwhelmed with our questions and it would slow down Taylor and Patty. So we're going to wait till the end to take those, and I'll read through those and get Patty or Taylor to respond to those. And then the agenda is Taylor will probably talk for about between 30 and 35 minutes on infection control and COVID-19 and what you guys can do to keep your community safe. And then Patty will come on with some practice management tips for about 10 to 15 minutes. That should get us about 50, 55 minutes into this thing, and then we'll have it open for questions as long as Taylor and as long as Patty have, we'll try to answer questions without keeping them too overly long. And we are extremely lucky to have Taylor to do this for us. Oh my goodness, I was reading his resume and his CV here, and he's done a lot in a short number of years, and so we're very excited. I won't read all the stuff that he's done because it would just make me feel sort of jealous. He's young and good looking and done all this stuff, so I won't. But there's Taylor's CV information, and he works with Southern Evals, and we do have a link in the previous slide there for his company as well, and there's one right there. And then Patty Harper, of course, with InquaSeq. She's fantastic. We all know her because she's done so much for the rural health clinic community. She's on the board of the National Association of Rural Health Clinics, and she just gave me the bad news that the NARHC meeting, I don't know if it's, and Patty, you can tell us if it's been canceled or if it's going to be redone or whatever, but she'll update us on that. That was just some breaking news just this morning that San Antonio is not going to happen this year. So there's Patty's information as well. I am going to switch over and let Taylor take over. And Taylor, you are now the presenter, and it's all up to you there. I will get your poll questions ready to launch as well.
All right. Thank you so much, Mark. And look, I appreciate everybody being on here. I know it is a pretty crazy time across the world. And, you being here really is a testament to the care you want to provide your patients and how you want to protect your community. So we'll get started. COVID-19 in your RHC. What we're focusing on is to be prepared, protect your patients and staff, and prevent the spread of infection in any way that we can. And so lack of education. I want to start with a small story. When I was a nurse just out of school in the ICU, one of the things that stuck with me, and it's why I am where I am today, is I had a manager. And that manager, he did what he could, but I finally remember I had one patient. And this patient still sticks out to me today. What it was is they had surgery, they had a surgical site infection, and they ended up in my ICU septic. Now, if you know what that, sepsis is one of those tough conditions to treat. And as a new nurse, I'm trying to soak up as much information as possible. What happened is I did everything possible that I could, but at the end of the day, it did not end out how I wanted to. That patient passed away. I went to my manager seeking help at that point, and he said, look, you just don't know enough yet. Keep moving on. At that point, I made a decision to say lack of education is no excuse to why I couldn't do everything else that I possibly could. And from that day, I vowed that I was going to focus on infection control and try to rid as many healthcare acquired infections and teach as many facilities the best practice that they could possibly follow. And that's when I started Southern Evals. And so what Southern Evals is a healthcare consulting firm, and we specialize in regulatory compliance. What we try to do is make just applicable solutions for healthcare when it comes to compliance. We make sure that the regulations are not a burden and you can follow those promptly and efficiently. And at the end of the day, we focus on trying to make our facilities and the folks we work with provide the best patient care possible. Who we serve, like I said, from the clinic down the road that's trying to get internet to listen to this webinar, we've worked with folks big and small. And what we see is these solutions can be implemented in any area. It just has to fit your culture and what your goals are. So a few of the things we do, like I said, the main thing, and we preach to all our consultants, is we help hardworking healthcare providers increase revenue and maximize efficiency. And we do that in a couple of different ways. You can see right here, regulatory compliance being one of those with the TCT and Quad ASF. Research, we help you research some of the best, if you're having issues, the best ways to solve those. strategy and development, if we want to do market analysis, feasibility studies, if you're looking to open a new service line, and then also ancillary services. So we're there for your survey. We do provide oversight, and we also do interim placement for those folks that need that. So let's get to what we all came here today to talk about. And what I want to do is break this down into 10-minute segments. So today I want to talk 10 minutes about COVID-19, basically what it is, some of the statistics that I found or that we're seeing. And a lot of this you may have already heard from different news outlets. I know there's a lot of people reporting on this, but I want to just take time to focus on this. Then the next 10 minutes I want to spend on evaluate. Our signature process in our consulting firm is evaluate, educate, and enhance. And so that first step that we're going to focus on is evaluate. What we can do to evaluate everything along the lines of COVID-19 to make sure all bases are covered. The next thing we're going to focus 10 minutes on is educate. All right, what do we need to be educating our staff on? What do we need to be educated on? And then what do we need to educate our community on to make sure that we're doing our part in preventing this thing from spreading? And then the last 10 minutes, well, actually it's going to transition. We're going to talk about enhancement. And I'm so excited that Ms. Patty Harper is here today. She is the MVP in my mind when it comes to RHCs and answering those questions. And it's just I've had the pleasure of working with her, and she's going to talk about how you can enhance your practice and other things that that are extremely important for you to know. All right, so the first thing we're going to talk about is about COVID-19. And so what COVID-19 was, it was a novel coronavirus. It was called 2019 nCoV, now known as COVID-19. And it was causing respiratory illness in people. And at first, they thought it was originated from the animal markets in Wuhan, China. They were seeing that the spread was from person to person. And early on in the investigation, they found out that this thing had a little bit more to it. You know, not a few isolated cases. It was spreading very rapidly. And then you see on January 30th, 2020, the World Health Organization declared that the novel coronavirus was a global health emergency. And I don't know if you saw yesterday, the World Health Organization came out and also labeled this as a pandemic. I knew it took a little bit longer than we thought it should, but they did all the research and they had all the data to say that this is a pandemic. On that same day, in January 30th, the Centers of Disease Control confirmed the first human-to-human transmission in the United States. And the tough thing about this, and we talk about us being the information generation, you know, when we want to find something out, if I've got to fix my pipes, I go on YouTube, I learn how to fix my pipes. Well, the complete clinical picture of COVID-19 is not fully understood at this point. And what I mean by that is we only have enough information from what we're getting from whether it be the CDC or state agencies. And I believe that is why a bunch of folks in our communities are getting worked up about this, is we just don't know everything about it. Moving on, when we talk about a global impact, we look at the areas that had confirmed COVID-19 cases. And, you know, whenever we had this map, we started educating our facilities on this. It's pretty amazing to see in a short amount of time how many places this has spread into. And, you know, a couple of the hot spots we were talking about was China, it was Iran, it was Italy. And we're starting to see some other places pick up the spread of this. And it's good to have a visual reference of where this is. It's pretty amazing. And now, as for our area in the United States, when we look at the confirmed cases, this is actually updating every day. You know, some of the statistics we found was saying that every 4 days, the confirmed cases double. And if, you know, when we look at that in the United States, you know, especially in my state, I look at from a Monday where we had 1 to today where we have 14. That's much more than doubling every 4 days. And so the spread of this is moving at an alarming rate. You know, when we talk about cases reported, this is adjusting every day, and that's why I wanted to add that resource at the bottom for the current count of cases. You know, one of the things, and you'll hear me repeat this, is read, stay up to date with what's going on so that you can have that information to share with your community. So who is at risk? When we talk about who's at risk, the first thing that really came out about this was any traveler. So if you had been to any of these hotspots that were having outbreaks of COVID-19, those folks were the first culprits that they were thinking were infected and that were spreading this infection. You know, when we talk about travel to different countries, we're going to talk about that in a few minutes about screening. That is evolving as we go on day by day, being that this thing is person spread. Also, when we talk about who else is at risk, we're talking about older persons. So statistically speaking, we talk about people 50 years of age and above with underlying conditions are at highest risk in severe illness. So what we look at in China, you know, they've done some panels and some studies. They're seeing that people 50 years and older with underlying conditions have a certain percentage death rate. If they were smokers or had respiratory illness, that death rate increases. And then also what they're seeing is that obesity adds to this percentage. So day by day, we're getting more research and we're learning more things about this. And we, you know, what we do is we try to push that out. An interesting fact about this, though, is, and a little bit of good news, is that our younger generation, 19 and younger, only accounts for 2.1% of those infected. And amazingly, what we're seeing is they don't exhibit symptoms. So that's something. It reminds me of hepatitis A in a daycare. You don't realize your child has it until everybody in the family has it. You know, they were infected, but they didn't have those signs and symptoms. So that's some interesting research that we've seen recently. All right, when we're talking about how this spreads, so in the beginning, they thought that this was spread from an animal vector. It evolved to person spread, and that's what the CD is saying now. Mainly how it is spread is from one person to another. And between people who were in close contact with one another, they said within 6 feet. And one of the things, especially that's unique to RHCs, and I think I saw Mr. Mark touch on this, is, you know, when we thought about this, this was very similar to the flu and it was spread through respiratory droplets. But with the information that the CDC has given us, they are advising us to practice as many precautions as we can. So when they say that, they're talking about standard precaution, contact precaution, and airborne precautions. And as you and I know, we do not traditionally have airborne isolation rooms or do not carry N95s in our clinics that would be able to handle a condition like this or similar condition that's an airborne spread like TB. And so we're going to talk about best practices when it comes to that. The droplets, when they talk about that, can land in the mouth, nose of people nearby and inhale in their lungs, and then also touching surfaces with viruses. Your own nose, mouth, and eyes can also cause infection. A case that reminds me of that is the lawyer and his Uber driver. You know, is that spread at that point? Was he coughing all over the vehicle, or was it spread airborne? And that's something we're still discovering. All right, when we talk about symptoms of COVID-19, we talk about fever, that's at 83 to 90%. You're going to have that in your patients. We talk about cough, that's 76 to 82%. And then shortness of breath, that's a little bit less, that's 11 to 44%. And it begins 2 to 4 days after exposure. So what that illness range is from mild respiratory to severely ill and dying. The dying or the death rate right now is at 3%, a little bit higher than the flu. And then some patients have reported early symptoms such as malaise, body aches, vomiting, and diarrhea. And what another interesting fact that we found out is a panel in Germany where they are having an outbreak. They found that whenever they had a group of people that they took and they tested these folks because they had been around someone with COVID-19, they had found that their viral load, which basically means the amount of infectious, you could just say bacteria that they were harboring and that they could spread to others, was extremely much higher than you traditionally see in a confirmed flu case, and that these people went 24 hours without symptoms. So I think as we evolve and as this disease and virus evolves, we're going to see that the traditional screening methods are going to have to adapt. Being that it's going to be hard to detect in those folks that are contagious but do not have those symptoms. All right, the treatment. So do not have any good news on this so far. And you know, working in the medical field, when we talk about something this new and we talk about a vaccine or a treatment on this, we usually are looking at about a year. This takes time. The research has to be done. You know, a lot of money is spent on this, but there's currently no antiviral specific for COVID-19 at this point. Supportive care to treat the symptoms is recommended at this point, and that's what they would provide in a hospital setting or in cases like this. And then for severe cases, treatment should include care for support for vital organ functions, basically just like any other extremely detrimental condition. All right, so we're going to close out that chapter on information about that, and we'll answer any other questions, but that's the basics as to what's going on with that. So let's open up this next chapter about evaluation. And when we want to talk about evaluation, I want to touch on a bunch of different things that we as clinic providers and staff in clinics, we can implement right now, and we need to be implementing. So the first thing I want to touch on is we need to identify and assess. And what we've done with our clients is we've walked them through a conversation. If they have someone or come into the clinic, or if they have someone call in on the phone or a telehealth encounter, this is what we're basically wanting to do. We're wanting to screen these folks for what the CDC and the state departments have put out that would identify this condition as of now. So the first thing is, do you have a cough, fever, runny nose, or shortness of breath? If not, then we're going to go and continue to ask those exposure and travel questions. But if yes, what we want to do immediately is place a mask on that patient and ask them to either use or alcohol-based hand gel or wash their hands. Then once that's completed, we want to continue. In the last month, this is the next question we're going to go to. In the last month, have you traveled to an area with a widespread outbreak or have had close contact with a person known to have coronavirus COVID-19? How we know about these areas, if they ask, we use the CDC's guidelines, or they have multiple different reporting agencies, and we have a few links with those. You want to update them and say, these are the areas that had the possibility of having those. These are the hot spots. Have you traveled to those areas? If no, we want to continue with that travel question that we have at the bottom. And if yes, and they have positive symptoms, that's when we want to isolate that patient to a private room. And so they have their mask on, then we want to take them to a private room. So we're going to move on to the next one. Have you traveled outside of the country within the last month? If no, we're going to, with our travel history, then we'll stop and we'll treat that patient as normal. If yes, then we want to start getting into our investigation. You know, what country have you gone to? When did you go? Where did, how long were you there? Or what was the purpose of the trip? So if the patient traveled to the hotspots, that's when we need to take action and notify the practitioner. And then the biggest deal is if yes, and they have positive symptoms, then we want to isolate that patient to a private room. And so at the bottom, we do have a note about if positive travel history or positive exposure history, but no symptoms, you want to tell that patient to self-monitor symptoms for 14 days and instruct them to contact the local state and health department if symptoms develop. And so this is the first piece that we can put into place. And over here, I'll put a respiratory illness and travel questionnaire. That's something that you can do right off bat whenever that person or that or anybody that's coming into your facility, you got to be hyper vigilant about making sure that that we ask them these questions. The next thing we want to talk about is isolate and contact. So adherence to standard contact and airborne precautions. So when we have that patient in that room with the mask on and they're in an isolated area, so we have to have strict adherence for all staff for all of these things that we possibly can do for precautions. So we want to place that patient that's suspected in a designated room. And here's another thing, we want to put a sign on the door, because if not everybody in that clinic does not know, then they may walk in there and be exposed. So we want to make sure we put a sign on the door. What we want to do is contact our local state public health authorities and tell them that we need this patient transferred. We suspect this patient is infected with COVID-19 and we need them transferred as soon as possible. Being that we do not have an isolation room available, they would need that. The authorities at that time would say, okay, send them in, or they would advise you, I've seen or I've heard that they would advise you to send them home if it's deemed medically appropriate, and they're going to put that call on the medical provider. When we're doing pending transfers, while this patient is in our clinic, we want to make sure, again, they have that face mask on and to contain those secretions, and we isolate them in an exam room with the door closed. And I think when we touch on emergency preparedness, it's good to know what room you're going to do this in. I would have a designated room so that there's no question about any of this, and we know the drill. We're going to touch on that later. And then, like I said, alert local Office of Public Health and the CDC for further guidance. They're going to give you the guidance as to what needs to happen next, and they're gonna help walk through that questionnaire to make sure that we touched all those bases. And what we've done at Southern Evals is we put together a list. That's the link down there for a list of all of your state websites on COVID-19, and then also contact information for the epidemiologists in your state. And so, we wanted to share that with you guys. The next thing is protect and track. So direct care staff, personnel entering that patient's room. If you absolutely have to enter that patient room, what we need to do is make sure you have your PPE on, including respiratory protection. And we're going to describe that in the next slide. Like I said, only essential personnel need to enter that room where the patient is placed. We only need to expose those people who have to care for that patient. You know, we don't want everybody going in that room. We want to keep just who saw that patient or who's going to be moving that patient through the continuum of care in that room. We also want to implement staffing policies to minimize the number of healthcare providers who enter each room. Now, if we have a large clinic where we have multiple people moving in and out doing different jobs, we want to make sure we minimize the number of folks who go into that room. And what we said is facilities should consider that when caring for these patients, that they have dedicated healthcare providers to minimize the risk of transmission and exposure to other patients. So, like I said, the whole point of this is we want to limit exposure to that suspected infected person. Also, this is something that I would advise, and I think the CDC would agree, is facilities should keep a log of all people who care for or who enter the rooms or care areas of these patients. And we're seeing this has been very advantageous whenever our larger counterparts like hospitals, they have patients that come in, they're not infectious, they get the test back, they're positive, and they've had radiology come in, they've had lab come in, they've had housekeeping come in, dietary. They're keeping a list and they know which employees had contact. That way they know who they need to test or who could possibly be carrying the virus. All right, your PPE requirements. This is, I know it's a recommendation for, or actually it's a requirement for RHCs, and you should have policies and procedures describing the recommended sequence for donning and doffing of PPE. We do not use these many times in an RHC setting, but we still need to know how to put these things on. There are many resources on the CDC on how to do that. And so when we talk about gloves, here's some hot topics that I always like to remind people of. Gloves to perform hand hygiene, then put on clean gloves upon entry into the patient room. Change gloves if they become torn or heavily contaminated, and then remove those when leaving the room and immediately perform hand hygiene. Don't take those gloves from one room to the next. We want to change those out. When we talk about a gown, we want a clean, disposable gown upon entry to that patient's room if we have to enter there. We want to change that gown if it's sold, and we also want to remove and discard that gown before leaving the patient room or care area. When we talk about respiratory protection, you know, this is something that we're going to have a tough time with as supplies dwindle and the presence of N95. So that is going to be the absolute best option. If you don't have access to those, we want to utilize surgical masks and dispose of those before and after, or actually before leaving that patient's room. Now, I do want to say this. We have a few facilities that are actually running out of supplies and masks. And we've gotten guidance from the CDC as to what to do with that. And I think especially as you walk through your emergency preparedness plan, you need to think through the possibility of what if we do run out of masks? What if we do run out of PPE and hand sanitizer, soap, all of the above? So it's something to think through. And the CDC does have explicit guidance on that, all the way down to where if you run out, we can use non-NIOSH approved masks or even homemade masks. Never thought I'd hear that, but it's something per the CDC. Eye protection, when we put on eye protection, goggles, upon entry to that patient's room, but just because of the nature of how it's spread, we want to remove that before leaving the room. And if they're reusable, we can clean and disinfect those according to manufacturer's guidelines, or if they're disposable, we can throw those away. All right, testing. When we talk about testing and priority, this is the we're going to talk about a few things. So this is the priority that we're getting advised to actually test these folks. Now, we wouldn't be testing these folks in our facilities right now. The CDC recommends that testing happens in an airborne isolation room. So what we'd want to do is, like I said, monitor, notify, and send out. But these, I just wanted to educate you guys on, this is what we're talking about. So the first is if they have clinical features and direct contact with a patient, that's going to be our top priority. When they have clinical features and they've had travel to an affected geographical area, that's our second. When they have those clinical features and require hospitalization but no other explanatory diagnosis, that's the third. when we have the surveillance samples and the community-based testing to detect, or actually what I mean to say by this is we have the ability to test this and to detect COVID-19 through these Sentinel sites. So your state has resources. I know my home state of Louisiana has put out that they do have these testing kits. But the deal is, and we'll talk about it on the next slide, the process is not as easy as we think it is. So at the end of the day, testing is a medical provider determination in collaboration with OPH, EPI, and the CDC. So what that means is that if you have a hunch, if this is extremely close to what we're talking about with these guidelines on testing, then we need to contact these folks, get further guidance, and then make the determination if they need to go out to be tested. When we're talking about testing, this is what is pretty interesting. So when we talk about private lab testing, maybe LabCorp, maybe Quest, anything like that, they have, if their test is positive, it's a preliminary positive. Remember that term. What that would have to do is be verified by your state lab. Moves to the state lab testing, if they get a presumptive positive, which we've seen a lot of those, presumptive positive means still they have to be sent to the CDC for confirmation. And then if it's verified by the CDC, most of the time your governor will make an official press release that's active. But get this, every test that they do has a 4-day turnaround time. So think about that. If we start with primary lab, we got a 4-day turnaround time, then it goes to state 4-day turnaround time, then it goes to CDC 4-day turnaround time. That's 12 days. So right now the testing is going to be extremely difficult with how this virus is spread. All right, and then as for emergency preparedness, we want to make sure you update your plan anytime there's a change or a new threat in the community or clinic, and update that emergency preparedness to include new threats. You know, it's going to be a good idea to evaluate your EPP, make sure it contains all those elements per your accrediting body, and then have documentation of your review. Make sure you're reviewing that, make sure you're updating that, and that you document that. What we've done is we have created a tabletop and a documentation exercise. If you need one, you can go ahead and grab that, and you can walk through that, those scenarios. You know, what if we have somebody that needs to be seen outside in the parking lot? What if we have the capability, we don't have the capability, or the phone lines go down and we can't screen these people and they keep coming into the clinic, we have an influx? What would happen if we run out of masks? All those situations are things we need to think through, and they're actually happening across the nation as we speak. So it's good to be prepared. And then the last is your inventory. We need to evaluate what you have on hand. You know, identify your stock, contact your supplier or your local vendors to make sure or see when supplies will be available, and then be resourceful. You know, be resourceful as to where you can find those things. Based on the local and regional situation analysis, face masks are an alternative, or an acceptable alternative when we cannot get N95 respirators. And this is what I say in our situation, we've got to use what we have. During this time, also, those respirators need to be used for those suspect patients or those at risk for highest exposure. So giving the general public masks is not recommended at this time. It's only recommended to utilize those masks and the short supply that we have for those patients that we think are infected. So just remember that. I know everybody's worked up and they're going to grab those masks, but you need to be the point of contact for that and make the determination if they need that mask. Or what's going to happen is, like we've been seeing, you're going to run out because everyone's in a tizzy and they take those to their house. So if there is a shortage of gowns or masks, you need to prioritize your activities. And then you also need to follow those guidelines as outlined out by the CDC on what to do. And it gives you a checklist as to, when you get down to those dwindling supplies, what you need to take care of. All right, a lot of information about what you need to be evaluating, but it's good to look into everything and try to identify every element. So we're going to close the chapter on that, and we're going to move into the educate section. So how we've broken this up is what you need to know as a practitioner, a staff member, and then also what you need to know about this for your RHC. And so the first thing is how to prevent it from you and your family is clean your hands often. And this is just something that, you know, as in my training as a board certified preventionist, this is the top thing that can prevent spread is wash your hands, soap and water for at least 20 seconds. I saw a post the other day. They talked about how, happy birthday, or at least 20 seconds. There's also some pretty creative songs like Come a Chameleon you can sing, or you can sing Jolene 4 times. Anyway, the point being is wash your hands at least 20 seconds after you've been in public places, blowing your nose, coughing, or sneezing. If soap and water are not really readily available, use the hand sanitizer. I know the stores are running out of that, and the CDC recommends that it contains at least 60% alcohol. Tito's Vodka has put something out that they're only 40% alcohol, so they don't recommend using your vodka to wash your hands. But again, if you do not have alcohol-based hand rub, wash your hands with soap and water. And then always, especially in flu season and with this going on, avoid touching your eyes, nose, and mouth with your unwashed hands. When we talk about for your RHC, constant reminder, look, review your hand hygiene policy and procedure and re-educate your staff on when they should wash their hands and how that's performed. You'd be amazed at how many people cut the water on, rub it a little bit, and then are done. We need to remind these people, or your staff members and the community, on proper hand washing policy. Also, we want to make sure you have plenty of supplies. So for your patients and staff, make sure they have availability to use those things. I'm a big indicator guy. I always talk about putting flyers up for hand hygiene around your clinic to encourage patients and staff to wash their hands. Always a good visual indicator. And then wash your hands when you walk into the patient's room so they can see that example. And then you can ask them, hey, have you washed your hands, or would you like to wash your hands? Motivate them to do their part in prevention and do your part to set that example. Moving on, we talk about prevention for you. Okay, we want to avoid close contact and stay home if you're sick. Look, when we're looking at all these things being canceled, we're talking about travel, we're talking about festivals, we're talking about sporting events, and it's because it's a large gathering of people and how this thing spreads so quick. So how to prevent it is avoid close contact with people who are sick. You want to put yourself at distance to others if COVID-19 is spreading in your community, especially this is important for people who are at a higher risk of getting sick. We're talking about our elderly. We're talking about those folks that have those conditions, predisposed conditions, or we're talking about the immunocompromised. And also stay home if you're sick. Except to get medical care and learn, you can learn what to do if you're sick. I think that's a link to the CDC, but they can tell you how to take care of yourself at home, to do your part in a non-prevention. And again, for your RHC, prevention is key. We want to educate patients, and I think Azalea, like they talked about earlier, has this ability. Is, do we have the ability to do those visits where our patients know that they don't need to be coming into the clinic if they have these symptoms and have all those predisposed those things on our checklist? Do we have the capability of doing telehealth to treat or to see those and screen those patients? And Patty's going to touch on that. Or what's our outlet of communication? How are we letting people know that if that is possible, that you need to contact the clinic either by phone or some kind of way before you coming in, and let us know about that? So those are things to think about. If possible, have a designated sick waiting area for those exhibiting symptoms. If that is possible, we want to keep those folks that are exhibiting those symptoms in that waiting area with masks, okay? If it's more indicative of COVID-19, like I said, follow your procedure, isolate those in their own room. And then we want to wear masks anytime working in close proximity to patients exhibiting respiratory symptoms. So this is the same along the lines of what we do with the flu, is if they're coughing and we're in close proximity, whether it be doing a clinical practice or whether we're in there just documenting or whatever it may be, if we're close to those patients, make sure you protect yourself and wear a mask. And then also you want to review your isolation precautions policy and procedure to identify the quantity of PPE and train on your donning and doffing of that PPE in your RHC. All right, this is just a reminder, your PPE requirement. Like I said, we've been through these, but gloves, gowns, respiratory protection, and eye protection. And like I said, know these things, because these are the things that are going to protect you and your staff. All right, prevention for you. We want to cover sneezes and wear a mask if you're sick. So cover your nose, mouth and nose with a tissue, or cough into your elbow. I know one of the craziest things we've seen is anytime we're going to shake hands. I'm a consultant by trade, and that's how we say hello. But now we've been having to give fist bumps or elbow bumps. Well, sneezing inside the elbow is what's recommended, but still a little iffy. Throw your used tissues in the trash and immediately wash your hands with soap and water for at least 20 seconds after you cough, sneeze, or have any of that, or utilize hand sanitizer. Also, prevention, you want to identify and act. If your patient is recognized coughing and sneezing, offer them a mask. Educate them on the importance of preventing this. Also have your flyers up front, have your masks in an area where they can see them, and then have your tissues. We want to reinforce the things that we're trying to practice as well. We want to educate the staff on respiratory hygiene and techniques. We can't assume that these folks have been taught this. Even though this is second nature to us. We live in that healthcare bubble, but this right here is a crisis. And, in this time of crisis, they need to be educated as well. Again, that's a summary. If you're sick, you need to wear a face mask. Unless you can't wear a face mask, then we need to do the best to cover those coughs and sneezes. If you're not sick, this is a big one. We see people wearing face masks everywhere. If you're not sick, you don't need to wear a face mask unless you're caring for someone who is sick and they're not able to wear a face mask. They may be in short supply, and this is the reason why we're saying this, and they need to be saved for the caregivers that are taking care of these patients. All right, one of the hugest things that we can talk about is cleaning and disinfection. And we need to make sure that these frequently touched surfaces on a daily, tables, doorknobs, light switches, countertops, handles, desks, phones, keyboards, toilets, faucets, and sinks are cleaned. And what we always recommend is, if you get in early, just everybody do their part, grab a bottle of wipes or grab some cleaning solution and just go around, make a quick wipe. It doesn't take very long to knock out the highly touched surfaces just to make sure that we're hitting those areas. Also be thinking about, I always say this, is ask your staff, what's one thing we haven't touched in a week? What's one thing that we hardly ever touch? If it's something that we utilize clinically, make sure we're cleaning that. Make sure we're looking into those things. If they're dirty, clean them. If they have soil on them, use detergent and soap, water prior to disinfect them, and then disinfect those things. And at the end of the day, clean, clean, clean. And what we've done is we've given you a list of disinfections that work against COVID-19. And so you have that resource right there. These are the things, like I said, just a reminder. Beepers are a thing of the past. Some people still use them, surprisingly. Stethoscopes, AccuChecks, pins, blood pressure cuffs, phones, wheelchairs, even phlebotomy kits or lab items, and then or cows or vitals machines. Anything we can think about that is getting in contact with folks with respiratory conditions or just on the daily use, we should be cleaning these things between patient use or at the appropriately. All right, so what we need to know for your RHC is the room clean? We got to re-educate staff on your room turnover process. Who's cleaning the room? How do they clean it? What it indicates? One of the biggest things we see is when we clean a room, we wipe a little bit, change the paper. Well, I want you to think about this as a process like an airline. An airline has a checklist, and I think we always advise for our clinics to have a room turnover checklist. Work from top to bottom, out to in, work highly touched surfaces with your disinfectant. And as the second thing says, understand what your dwell time is on your disinfectant. A kill time, a dwell time. What this means is on your product, it's going to give you a time that has to stay on a surface to make sure that it does its work and kills everything that it says it kills. All of this is on your bottle of cleaner, or if you need to get data, you can search on the internet and they will give you what your dwell time is, but you got to make sure you respect that, because if we don't respect that, then that cleaner is not doing what it needs to be doing. Then this goes for all areas of your clinic. So when we're looking at the reception, when we're looking at our break room, when we're looking at bathrooms, when we're looking at labs, this is for everybody. And at the bottom, what we've done is provide a link to the Infection Prevention and Control FAQ for coronavirus that talks about cleaning. And you can use that as a resource. All right, we're going to close that chapter, and now we're going to move into enhance. So what we've done to enhance is we've been in survey and we've vetted these resources with our state surveyors. And right now, I'll just give you a little bit of insight. They are in the same boat as we are. They're finding out information every day. They've been on the phones, making sure that they do what they do. But what we've tried to do is put out resources. And so we have a policy and procedure. We have a program plan. We have an intake form with a questionnaire. We have a person under investigation form. We have staff education that you can use with your staff, and also a competency tool with a key for you to use. We also have a tabletop exercise with the documentation and an intake flyer you can put up front. And so that's a link to all those resources in that we call it our COVID-19 booster kit, I believe. And now the last thing is everything is figure outable. Look, this is one of my favorite sayings. I use this with a bunch of my clients, but anything we do, even a condition like this, we're going to figure it out. We're, you know, at the end of the day, it's just going to take some time. It's going to take some research, but anything is figure outable. And when we talk about what's figure outable in our clinic, we can figure out what we can do and what we can control. And then we've got to be good stewards. And I know you being on this webinar means that you want to do what's best for your patients. You want to do what's best for your community. And I commend you for that. And this is the last thing I got for you. Screen, 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 clean, 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 and read, 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 okay? When you have folks come in, make sure you're screening those in any possible way you can. Make sure you're cleaning anything and everything. Also, you know, think through if you're bringing anything home, make sure to be vigilant about that. And then read, read, read. All these different resources that you have, you want to stay up to date. And I know state organizations have been doing very great on that. But that is my, that's all I have for you. And I'm going to turn it over to Patty right now.
Hey, Patty, this is Mark. I'm not hearing
Okay,
anything
I got you.
from you. Okay,
Okay, all right,
Uh-huh.
I'm back. Okay.
Okay.
Hi, guys. Sorry, this technology is great when it works.
Yep.
So we're going to talk about some of the same things that Taylor did. We're going to address them more from a practice management perspective. So some of the things that you hear may be a little bit redundant, but in the education process, it's always good for us to be a little bit repetitive. The pre-screening and the screening of patients. So we've talked about this quite a bit already on the webinar. So these are some of the same questions that Taylor had you ask. On my slide, I do not have shortness of breath as a symptom. So if you're doing that screening, we want to make sure that we add shortness of breath. Another thing that we push out to our clients is we have a travel poster that they can also put in their waiting room, which also prompts the patient to remember to mention if they have traveled anywhere. And that's especially good for this COVID-19, but it's also good for other illnesses that are transmitted during travel. So one of our main products that our company offers is our IncuDocs, which is a full rural health clinic compliance program. That travel poster and some of the other tools that you have seen on the screen are in our library. So we want to educate the front desk. We want to educate them about how to ask these questions. And so from a practice management perspective, you're going to need to make sure that the front desk, the person who answers the phone, is comfortable asking and engaging with your patient. So that may take a training session on your part. It may take helping to script or role play with your front desk. Again, our front desk is our most valuable resource in our clinic, and often they're the ones that get left out of the loop on training or on communication. So we want to make sure that we know which questions to ask, that the front desk is comfortable to ask those questions and to engage with those patients. So it's easy to do over the phone if you're scheduling appointments. If you take walk-in appointments, you're going to also need to have a screening process in place for those walk-in patients. Depending on the privacy of your registration desk, it may be better to give the patients a paper questionnaire to fill out, or if you use a tablet for your registration, maybe incorporate those questions on that tablet as part of the history of present illness or part of the chief complaint. This is the same travel questionnaire that Taylor showed you. Again, I would add shortness of breath to that because that is one of the main symptoms of the current virus. If you would like this questionnaire, I don't think we have it on a link for this webinar, but my email is included in my slides. If you want to email me, I will be more than glad to send you this questionnaire. When we talk about travel outside of the country, I want to go back and say sometimes people don't realize they've traveled out of the country, or they don't consider a destination wedding or a hunting trip to Canada or Mexico as being out of the country. Again, on our travel poster that we have a good prompt for that. Your protocol for screening patients is going to depend a lot on the risk of your particular clinic. So you're going to want to conduct a tabletop exercise scaled to your facility. There are tabletops out there on the Ask for Tracy website, also on the World Health Organization website. A lot of those exercises are meant for larger healthcare systems, so you'll want to have an exercise that is scaled to the size of your clinic. And are you in a geographic area where there already are cases? Are you in a geographic area where there are a lot of cases? And again, like Taylor said, we're seeing those numbers, double, triple, quadruple in a very short period of time. Do you have known exposure in your area? Does your community have an industry or a manufacturing company that is known to have international travel? So what are your risk factors for your clinic? That's going to depend on how you prepare for this pandemic. Your patient demographics. Do you have pediatric patients? We already know that they are less susceptible to actively having the illness, but they may be able to be contagious to other people. Are you mainly older Medicaid population? And then your provider judgment. The size of your clinic has a lot to do with how you prepare. So we have problems with clinics that are either very small or clinics that are very large. How are you going to designate that space where you're going to isolate that patient if you're in a clinic with only 2 or 3 exam rooms? Likewise, if you're in a very big clinic, how are you going to get that patient through your clinic with the minimal exposure? And you're going to need to know your availability for referral and transfer and admission. So this may be a good time for an independent clinic to look at their transfer agreements, to look at your agreements with EMS, to contact those other healthcare providers and find out what the processes on their end are going to be if you do need to send a patient to them, or you do need to request transport of a patient. So these are things that are going to go into your risk assessment and into how you prepare for handling this emergency situation in your area. You're going to want to develop protocols like Taylor talked about. How are you going to deal with patients that are high risk as opposed to those that are just having general respiratory symptoms? How are you going to do that? So these are just an example of maybe how you would develop those protocols. Exam room cleaning. You need to clean as if a surveyor is going to come to your clinic every single day that we're in the middle of this crisis. If you're a new clinic, you probably have just been through survey. You know how picky the surveyors are on cleaning, on disinfecting, on turning rooms around, on making sure that employees know how to use their PPE. If you have been a clinic for a long time and you haven't had a survey, you may need to refresh all this and go back over this. It's human nature for us to get a little bit lazy, for us not to do as good a job as we did in the beginning. So this is a great time for us to kind of start over in the way that we approach cleaning our exam rooms and our waiting rooms and those areas that have surfaces that get touched a lot. If you're a clinic administrator or you're a clinic manager, this is when you're going to want to look in your policies and procedures. You're going to want to look in your infection control plan. You're going to want to look in your emergency preparedness plan. What do we need to revise? What do we need to retrain on? Do we even have a pandemic event in our risk assessment for emergency preparedness? So this is a time where we need to go back in and make sure we have everything in place that we need to administratively. And then it may fall to you to be in charge of retraining on these different things. So anytime we have a major change in our situation, our emergency preparedness plan is supposed to be updated. We're supposed to do that risk assessment again. And it's a perfect time for us to retrain or train our staff on any revision that we make to this. And these are just some of the things that, that we may need to go over. The last bullet at the bottom of this slide, I want to talk about we really need to communicate with our staff that we do not want them to be working if they don't feel well. For a lot of our employees, if they take time off, that means that they don't get paid. It means that it puts them in a financial burden. So we may need to think about how are we going to accommodate this staff if we do have staff that we do not want to work when they're not feeling well. We may need to have extra PRN staff lined up. We may need to include in our emergency preparedness plan what our provision is going to be if we have a staff shortage, which is very possible. So again, from a clinic manager, clinic administrator, provider perspective, you want to review these policies and plans. We also want to be very transparent in our communication with our patients. Everybody's nervous. Everybody has news on 24-hour news. Your patients need to be reassured of what you're doing to contain the infection, what you're doing to screen and keep them safe. Your employees need to know what you're doing to keep them safe. So we really need to go the extra mile on communicating clearly with our patients and our staff. Our patients may have to wait a little bit longer than usual if we're doing a more thorough room turnaround, or if the screening process is taking a little bit longer. So communicate that to them so they know, and reassure them that we're still going to follow HIPAA, that privacy, confidentiality, and security are going to be safeguarded. In an outbreak like this, we will be required to report our patients to public health officials. We will be required to ask them who they've been in contact with, but our HIPAA need to know requirement is still in place. In our small town, it's really tempting. Oh, can you believe Mr. Jones was in here and we think we're sending his lab work over. We think he's positive for the coronavirus, you know. So we need to be very careful that we follow the HIPAA regulations. And we want to educate both patients and providers, which a lot of my slides are going to do that. Taylor talked extensively about the use of PPE. Here are two links to videos. The first one is the CDC guidance for selecting and using PPE. And the bottom link is actually to how to put on and take off PPE. It actually is from the nursing exam review, and it has exam questions at the end, so it would be great for you to use for staff training. Wanted to include that. Other CDC resources, they have a wonderful selection of hand washing posters. They are geared to adults, they are geared to children, different education levels, different ethnic and demographic factors, so you can find the perfect poster to use in your clinic. They also have fact sheets. So posters are mainly illustrations, and fact sheets actually have text on them. They actually have more content. Both the posters and the fact sheets are available in English and Spanish. So then again, you can find the one that's most appropriate for your population. What we want to do with these posters and fact sheet is we want to find the one that's best for our patient population. We want to laminate those, again, so that we can wipe them down and prevent the spread of germs if those posters or fact sheets are being handled. We want to strategically place them around our clinic. So we want them in our waiting room. We want them in our patient information binders, in our restrooms, exam rooms, food service areas. And we may want to have paper copies available as patient education tools. So again, all of those are downloadable from the CDC website. There also are videos. So if you have a big screen in your waiting room or you have a patient education system, you may be able to upload these videos. This is one, everything you need to know about hand washing. There's another one that's very, very kid friendly. So you could also use these videos on your big screens, on tablets, in your patient education system. Anything that we can get out about hand washing, because we know that is the number one thing for anything that we're going to do to prevent the spread of disease. They also have podcasts, really short podcasts available on the CDC website. So you can download those. You can play those in the car with your own kids. One of them has a hand washing song on it that's real cute for kids. We can provide these links for our patients so they can watch these videos or podcasts at home. As part of your community outreach and maybe as part of a community emergency exercise, you could partner with daycares, Head Start programs, schools, civic organization to get some of these resources out into the community. And you might want to think about one of your providers or one of your administrators being a guest lecturer at a community event like a Kiwanis Club or a Lions Club meeting, again, to get out correct information about the virus. Other CDC resources are printable stickers. So if you're a pediatrics practice, you can go to your office supply company, you can order, you can get stickers, and then you can download the file from the CDC and give your kids stickers. There are social media badges and buttons that can be used on your Facebook pages, posters, fact sheets, a more detailed campaign, videos, and podcasts. So the link at the bottom is where you would find all of those things. And here is my information, my email and phone number on the top of this screen. And so, Mark, I think I'm done. We can probably take questions. So
yeah, you want Patty? What I'll do? Thank you. First off, thank you, Taylor, and thank you, Patty, for doing this. Taylor, if you want to unmute your line, there you go. I don't know if you can see the questions here, but I've got the pane sort of unhooked from the sidebar. And our first question, Patty, you probably, let me see here. Well, yeah, you can probably answer this one. Is there a discussion of reimbursement for RHCs to be able to treat patients over the telephone if COVID-19 becomes an issue, making it unsafe for sick patients, diabetic, cancer patients to come in for their regular appointment? So, Patty, I'll let you take the first stab at that one, because you will probably know the answer to that.
Okay, thanks, Mark. So you may have seen that CMS published that some of the rural health clinic some rural providers, the telehealth medicine rules were going to be waived. Unfortunately, that does not apply to rural health clinics and critical access hospitals at this point. But we were talking with Clark before the webinar started. You may choose to use telemedicine or use some type of remote patient communication, even if you're not going to be reimbursed for it, just because it's better not to have that patient come into the clinic and impose that risk on your clinic. Now, what we can use is we can use the virtual communication services codes. And if anybody wants to email me on how we use the virtual communication service. So this would be your rural health clinic provider engaging with a patient through text, through your EHR portal, by phone or by email, that does not result in the patient coming into the office. So for your patients that seem to be high risk that we would not see in the clinic anyway, we probably would direct them to go to a facility that's more able to care for them. You could use the virtual communication service. That is it does not pay our encounter rate. It pays about $14 and we receive that as a payment if we communicate with that patient electronically. As far as telemedicine, we still have restrictions for rural health clinics where we cannot be the distant site. But again, you may want to set something up because rather than have those high-risk patients come into your clinic, you may want to screen them in another electronic format. Mark, you want to add something to that?
Patty, I think you covered everything. I had my little notes about the virtual visit, $14, 5 minutes. You got it all covered. So, and since we are sort of going over our own time, this one here is probably more down Taylor's avenue. So, Taylor, assuming that a person is relatively healthy with no underlying health issues and contracts COVID-19, generally, how long is the infection period? That's the first question.
Yeah, usually we're seeing, especially the infection period of right around 14 days, just because they're wanting to make sure that the symptoms are resolved and that the viral load is not able to be transmitted at this point. I know the guidance from CDC is, gets updated every day, but really that's typically the cases that we're seeing. And it does differ in age groups. And they've got a great resource. I'll have to remember where it came from, but they talk about the folks that have been infected and the folks that have been through this virus and have resolved all clinical symptoms. Now, I will mention this is that we do not know at this point, the CMS has not given us guidance to say whether you can be reinfected or you do gain an immunity to this, because like the flu, you can get flu A, but then you resolve of that and you can get flu B at the same time. This is something that we're going to continue to study, but that's what we've been seeing. And I know that as more research happens, we're having more cases of folks that have been treated and just taking precautions. It's going to be about that long. Now, we'll say this as well. Whenever we do see cases coming into the hospital and they're over that age rate and they have comorbidities, we are seeing sometimes in some of the worst cases that they are having to be ventilated within 48 hours because the symptoms do get that bad. So like I said, that's what we know as of now, and we're going to stay abreast to see what we do see coming up in the future.
Okay. Taylor, the second part of that question, I think you answered that in that was if a person contracts or is exposed to COVID-19 and recovers from it, is that person immune from it like you would be from chicken pox? And I think your answer was, we just don't know yet. Is that what the answer was?
Yes, at this point, I know they're doing research in Germany and Italy right now of nurses that have been in contact who have got the disease. And, what they're trying to do is utilize those nurses to take care of those patients. We have not seen any reinfection at this point, but I think it's too early in the game to say whether it is possible or not.
Okay. And then, Taylor, sounds like a question for you too. How long can COVID-19 virus live on a surface or anywhere outside of a body? And they're probably finding this answer out as well, but what's the latest that we know?
Yeah, there's been no literature as to how long it lasts on a surface. I know just the guidance that we've had is that on that list of cleaners, we want to make sure that we use those and we utilize those to the maximum dwell time that they require. So if that wipe says 2 minutes, we need to make sure that it stays on that surface for 2 minutes. But as for guidance on how long that it stays on the surface, they are saying that it can stay on the surface for a couple hours. I think that's the latest that we've seen.
Okay, a couple hours. Okay. And then this one I can handle. Will the slides be emailed out? Yes, we emailed them out to almost 500 of you guys before the webinar. We have a link to those. We set up a website called, it's on our normal website, ruralhealthclinic.com. And then we just put a backslash COVID-19, and we have all the materials on here, all the links that our presenters have presented today are on there. Although after seeing the presentation, I think I missed a few of them. So I'll go back and put the rest of those links on there, because I want Taylor's, I think I missed maybe 2 or 3 of those. So I'll make sure I'll get those in there. And then we had another question about somebody having a hard time getting the slide presentations to download. I will double check our website and make sure that we are able to download those. Sometimes when they're in the handouts over here, GoToWebinar doesn't, if they're larger files, sometimes they won't download from GoToWebinar. So I would go to this same website as well. Okay, let's move down here. Patty, if you want to try this one, we are pediatrics. Should we be screening the parents or caregivers that come with the patients?
Oh, that's a great question. So yeah, we want to make sure not only has a patient been exposed to those risk factors, or anybody that they've been in close contact has those risk factors. So that would definitely include parents, extended family, caregivers, neighbors. And so, you know, you might have to get a little bit nosy. And if I was a parent with a preschool child, I'm a grandmother with preschool children, I would want to know what my school and my daycare are doing, and how are they going to communicate with me to let me know what is going on in those settings. So yes, we definitely would want to expand those questions, maybe reword that screening questionnaire to bring in those groups. That's a great question.
Okay, and Taylor, do you have any more to add to that?
I will say this, you know, I know we've heard a lot, you know, just along the lines of it is fairly new, and it's really tough to make calls as we see them. But I will give you, you know, a little light in this is, you know, when they look at preparedness when it comes to a pandemic, United States ranks first. And so I do believe that the CDC will have literature coming out talking about more of these items, giving us more details. And that's kind of what I see happening. I do think that this is not going to be a coronavirus storm. I do believe this is going to be similar to a coronavirus winter, where it'll be a couple of months, 6 months, and I think we're just getting started into this. But like I said, I think we have, you know, we have everything that we can do at this point to you know, to protect our patients, to protect our kind, and we can do everything in our control to prevent the spread in our communities.
Okay, Taylor, looks like I skipped over one of the questions here. It says specifications for reusing mask, and then I guess this question is new mask per each patient. So what is the recommendations on that?
Absolutely. So whenever we called the CDC yesterday, I had a case when those masks were starting to dwindle, and the guidance they gave us, and I can share that link on the page as well, is that whenever our masks start dwindling, we want to make sure that we are restricting those masks from use from the public. We're only using those for our symptomatic patients and for our healthcare providers. They said if our supplies get low, we need to reuse the masks that we have or use what we can. And prioritize clinical practices. And then they went on to say if we actually run out of masks, we want to make sure that we have a plan to try to resource other non-NIOSH. And so NIOSH is the organization that approves these masks for what they can particulate, basically what they can filter out. And we have to start looking at other solutions. And then the last resort is homemade masks. And so that's kind of towards the end of the spectrum. But I will say this, as early in the game as it is, we are seeing lack of supplies, and that a lot of these big group purchasing organizations or these large folks like Medline are limiting the amounts, and they're limiting to the folks that have not ordered in a timely manner. So if we hadn't ordered masks in 3 months, they're prioritizing those folks that order them every week, you know. And I think that I think we need to do, you know, kind of follow those guidelines. And then at the end of the day is be resourceful. If we don't have those, we need to be resourceful as to how we try to protect ourselves.
Okay, thank you, Taylor. And Patty, let's give you this next one here. If you have an employee that is going to Mexico for vacation, that sounds nice. Do you recommend having them quarantine for 14 days, or only if they travel to a country that is considered to be a high-risk country?
Oh, so that's a great question too. So as Mark mentioned, I'm on the National Association of Rural Health Clinic board, and in all of our discussion trying to decide what we were going to do with our upcoming conference, this came up because a lot of the larger healthcare systems and even some of the smaller hospital systems are restricting travel for their employees. And so if those employees choose to take personal time, like vacation, to travel, most of those organizations are requiring that those that those employees self-quarantine for 12 or 14 days. So that definitely is something that that you need to think about, maybe part of your tabletop or part of your risk analysis. You know, we're coming into springtime when people are getting married and they're doing these destination weddings to Mexico or the Bahamas or wherever. So that's going to be something you're going to want to look at your policy for. But from what I've understood, most hospital systems are requiring their employees to self-quarantine if they choose to take personal travel that puts them at risk.
Okay. Thank you, Patty. Okay, and Taylor, here's one that looks like it'd be good for you. If our lab test is negative, will it continue to state or does it stop there? Or will it continue to the state or does it stop there?
So basically, whenever we're talking about laboratory testing, if we do have patients that have respiratory symptoms, what our guidance has been is we want to factor out other conditions. So the first thing we want to do is if they have similar or symptoms similar to the flu, then we want to swab them for flu. If it does not come up at that point and they are suspect, then we would take it to another level. As for and I'm not quite understanding the question, but is it a question about if we're going to be screening from our lab organization in the clinic? What's the next step?
I don't know. Maybe as soon as we get through these written questions here, we'll open up the lines, and I think I've got a couple lines that are people if they've raised their hand. So Nancy, if you want to raise your hand, as soon as we get through these, we'll come back and we'll let you give us a little more context of the question. And then let's move on because I know we're running out of everybody's time here. Keisha's question is, what is the virtual communication code? Patty, we'll test your memory and see if you can remember what that code is because I can't remember it.
Oh, you know, I just thought about that. I should have written it down. If someone will email me at pharper@inquaseq.com, I will send you the fact sheet for RHCs on virtual communication and the code information. I'm sorry, I was unprepared with that.
Okay, she says it's G0071. It's real simple to find that too. If you because I end up looking this thing up just about every day here recently. Is if you just Google RHC and then a space and then ASP, you're going to go to the RHC CMS website, and they've got a thing called Spotlight. It's the first thing you see, and it talks about virtual visits there, and it's got the FAQ. It's got everything you need to know about a virtual visit. So that's if you just Google RHC and then ASP, which I don't know why, but that always works. And so that'll be the first Google thing that you'll get. Your Google hit will be that. So okay, virtual communication. Next one on here.
Thanks, Mark.
No problem. As rural health clinic nurses, we are wondering how to test in the office, or do we send the patient to our local health department, which is in our town? Taylor, that sounds like one of yours, probably.
Yeah, absolutely. So as of right now, the CDC has given us communication that any testing for COVID-19 has to happen in an airborne isolation room. And so what that means is it has to have a certain amount of air exchanges in this room. It has to be basically built to pull the air outside of that room and then exhaust it to the outside. And unfortunately, in our clinic setting, we're not able to do that. So what they're recommending is that if we have a case and it meets all those designations, if it's top priority, then we contact our local office of public health, our epidemiologist and the CDC, and then work through with them if this is a case that needs to go to be tested. Another recommendation that we've seen is if they do have that, they're gonna and their symptoms are not that bad, they're gonna say, okay, we're gonna monitor those folks, send them home to isolate themselves at home, and we're gonna keep in touch with those folks. But that's the guidance that we've been given. As for testing, I know that especially when I'm keeping track of what we're doing in our state, they are recommending that our outpatient clinics send those to the appropriate places to be tested because those places are getting in contact with the state, can do those tests, and have the availability to do those tests.
Okay, and Taylor, looks like we got one more question, I think, for you, and then we got one for Patty, and then we'll open up the lines. for Taylor, regarding gowns, are there specific gowns that we should be wearing? And like ANSI, AA, MI, PB, 70, levels 1, 2, 3, or 4?
I'll just say this is at this point in the game, whenever we're talking about conserving, reserving your supplies and having what you need, in all practicality, use what you have. Because as of right now, if you do not have like the highest grade ANSI or AMI recommended gowns that are fluid resistant, what they're going to recommend is just to use the gowns that you have. Traditionally, what we want to do is we want something that can that can prevent, if we do have those droplets, it would stop those droplets from getting on ourselves or on our clothes. And then for those gowns, what we want to make sure is that we dispose of those. And if we start running out of those, that if it does come to the case that we reuse those, we make sure that we keep those in the room. But again, I would recommend to just use what you have. And if desperate times come for desperate measures, then I'm not saying go get a shower curtain and wrap it around yourself, but like I said, just use what's practical, use what you have, and then be resourceful.
Yeah. Did you see the news report where in Memphis, where they were like getting plastic bags from the Dollar General and wrapping themselves in it? That will probably not do you a whole lot of good. Let me just tell you.
And I still can't understand the reason why all of our shelves are going with toilet paper. I'm still trying to figure that one out. But
when I was driving to Kentucky yesterday to work with the clinic there, when I went in to wash my hands at the getting gas, there was some guy that was actually stealing the hand sanitizer from the thing. He'd opened it up and taken it out. I was like, well, can you give me a squirt of that before you steal it? I mean, it is crazy at this point. It really is. And then last question before we go open up the lines here: how can we access the question sheet to screen patients? I think Patty had offered to email it to them. Both of you have a way to get a hold of that. So why don't y'all both tell us how to get a hold of that questionnaire? Patty, you want to go first?
Well, you can email me, or Mark, if you want me to, I can send you a copy to put with the other links on your page.
Yeah, that'd be easier for you. And I'll be glad to do that. And then Taylor, is that a part of you? It sounds like you have a product there where you probably just click in, and I've seen that your prices are very super reasonable.
Yeah, absolutely. And that's what we put that together, basically vetted from the state surveys that we've been through for the condition of this so far, and it has all the resources that you need. It does include that screening sheet as well.
Yeah, so that's what I would recommend. In fact, I'll probably be going on there and purchasing one or two of those myself, so I know exactly what you have there. So I'm going to look now for somebody with their hand up, and I saw it, and there's so many of you still in here. Thank you guys for hanging on here. We still have 200. Teresa Kelly, she's had her hand up for a while. Let's see. Oops, and there's so many of you. When you leave, it moves, so I clicked the wrong person. Here we go. Teresa Kelly, I'm gonna try to. No. Stop leaving, people. There we go. Teresa, I just opened up your line. You can ask us a question now.
Well, no, I'm the one that I ended up writing a question about screening the parent. So you've already answered it, but thank you.
Okay, no problem. Thank you. Okay, and then let me see here. And I'm going to try to unmute your line, but don't move on this. Okay, good. Okay, so yours is unmuted. And another quick look through here. I'm not seeing any more hands open, so I think we've successfully made it through. Taylor, Patty, thank you so much. It's been so helpful for everybody that's still on here. This has been recorded. It'll take about 30 minutes to process the recording, and we will put it on the Rural Health Clinic Information Exchange. I will put it on that RHC, ruralhealthclinic.com COVID-19 website as well, so you can link to it and get your hands on it as well. Thank y'all so much, and be safe out there. I know it's a dangerous, scary time for everybody. I think we're going to stop. Yesterday was my last visit to a rural health clinic for several weeks. It comes at a good time where cost report prepares. This time of year, we sort of isolate ourselves anyway. So that if there was a good time to have one, this is a good time for us poor old cost report preparers to do this. So thank y'all. If you need anything, if something doesn't work as far as downloading stuff, just let me know and we'll get working on it as well. All righty. Thank you. I'm going to end the webinar now.
Thank you.
Thank you. Let's see here.